Good evening, everybody. I'd like to get started tonight with our March Neighborhood Health Series. Thank you so much, everyone, for joining. It's nice to see some familiar faces and names here with us tonight. I'd like first to thank Clark County Credit Union. We have Craig Fraley here. Without Clark County Credit Union, the Neighborhood Health Series would not be possible. We're very, very grateful to have them as a community partner. And with that, I'd like to introduce Craig Fraley and let him say a couple of words.
Thank you, Vanessa. Good evening, everybody. As the Medical Field Credit Union, we are very proud to sponsor Roseman's Neighborhood Health Series. And as usual, if you have an allergic reaction to big banks, we have the cure. Give us a call at 702-228-2228 or visit us at our website at ccculv.org. I hope everybody has a wonderful evening and enjoys tonight's presentation. Back to you, Vanessa.
Thank you, Craig. Thank you for all you do. Okay, we're going to get started. I'd like everyone to know that I am recording this session. This session will be posted on the speakers.roseman.edu website. So you're always able to see or forward this along for folks that you'd like to share this with, and also to view for upcoming issues. We are going to ask that you put your questions in the chat function at the bottom, and we will gather those questions up, and we potentially will stop and answer those along the way, and then we will open it up at the end of the session for questions. Okay, so with that, I'd like to introduce you to Cure for the Kids. Cure for the Kids is a Roseman University partner. We are immensely proud of Cure for the Kids' work. Cure for the Kids sees roughly 100 patients a day right next door in our Summerlin campus. Children that have pediatric cancers as well as blood diseases. They are seen regardless of their ability to pay. So Roseman is very, very proud to have Cure for the Kids as one of our partners. With that, I'd like to introduce our speaker tonight, Dr. Joseph Lasky. Dr. Lasky joined Cure for the Kids in 2017 and is currently the Director of Pediatric Neuro-Oncology. He attended medical school at the University of Illinois at Chicago and did his pediatric residency at the University of Chicago. He completed his Pediatric Hematology Oncology Fellowship at UCLA in 2006 and was director of the Pediatric Neuro-Oncology program at UCLA until 2009, when he moved to Harbor UCLA Medical Center in Torrance, California, and was named chief of the Division of Pediatric Hematology Oncology. While there, Dr. Lasky became involved with a number of clinical trials for patients with bleeding disorders, including hemophilia and von Willebrand disease, as well as sickle cell anemia. While continuing to have research interests in pediatric brain tumors and immunology, he's also interested in running and developing clinical trials for patients with bleeding disorders and sickle cell anemia. Dr. Lasky is a member of several professional societies, including Children's Oncology Group, Society for Neuro-Oncology, American Society of Hematology, and the American Academy of Pediatrics. He enjoys watching sports, reading, music, and outdoor activities with his family. We're very happy to have you. Please join me in welcoming Dr. Joseph Lasky.
And thank you, Vanessa, for that kind introduction. And I guess I'll go ahead and try to share my screen. All right, everyone sees that okay? Cool. So I've given a few Zoom lectures, I guess, presentations over the last couple of years, but in general, I think I generally feel more comfortable in front of actual people, but hopefully we can make this a little real. But I'd like to, keep this, relatively informal, and definitely feel free to put questions into the chat room. And when I get, little breaks between slides, I'm happy to take those questions and answer them as they come, or we'll have more of a chance, I think, at the end to open it up as well. But again, I say welcome to you. And as was said, I'm a pediatric hematologist oncologist at Cure for the Kids Foundation. I'm going to make my pointer into a laser pointer. There we go. This is a fairly broad talk, and I was going to focus, mostly on benign bleeding disorders, but I am going to touch on leukemia and some of the childhood cancers a little bit too, just to, give some information about those. But I wanted to start out by just kind of, and I have no disclosures, start out by, giving you an idea of what pediatric hematology oncology is all about, at least here in Las Vegas. For the most part, at Cure for the Kids, we're kind of jacks of all trades. So in other words, the 6 hematologist oncologists that are here, we don't particularly specialize in one area, but we do have kind of our focuses. For example, I'm generally interested more in the bleeding disorders and then in brain tumors, but we for the most part take care of all sorts of pediatric hemat problems. And so the things that those kind of entail, first of all, obviously oncology or the cancers, those are our top 3 things we deal with, at least in the pediatric world. Obviously adult oncology is quite a bit different, but leukemia being by far the most common, and then followed by brain tumors and lymphomas. From a hematology standpoint, which I'll be talking more about in a sec, we take care of a number of bleeding disorders, and then also clotting disorders where people clot too much, and then also a number of congenital anemias such as sickle cell, spherocytosis, thalassemias, and whatnot. And then finally, there's quite a bit of kind of other stuff we get visits and consults for. We are often kind of the first line consults for immunodeficiency states, although if those get more difficult or complicated, we do want to get those to immunologists, but oftentimes we do provide the initial workup for those type of things. And then that kind of leads into neutropenia, which is just one of the type of white blood cells that can be low in patients, called neutrophils. And then we get a lot of referrals from patients with certain genetic disorders such as trisomy 21 or Down syndrome, who are patients that have a little bit higher risk of getting certain malignancies such as leukemia, and oftentimes the pediatricians want us to just follow along and make sure there's nothing going on. And then we get a number of referrals for stuff that other doctors can't figure out, and some of the time we do figure it out, some of the time we don't, but we do our best. So that's kind of, like I said, a broad overview of what I do as a peds hematologist oncologist doctor. So I'm going to kind of start from the beginning, and as many of you know, things tend to start with the genes. One could argue that everything starts with the genes. And of course, in all higher mammals, genes are, all higher animals, genes, of course, are arranged in double helices in DNA. The DNA has a number of alleles or coding sequences that then are turned into messenger RNA that then ultimately get translated into the workforce of the body, which are the proteins. And in all of us humans, we have our DNA, of course, arranged in chromosomes, and almost every cell in our body has 23 pairs of them, half of which we got from our mom and half from our dad. Oh, sorry, let me get rid of this. Okay. Oh, you guys don't see the screen here, do you? Or the...
We see it.
Oh, do you just see my PowerPoint?
Yes, and I see the pointer as well.
Oh, okay. There.
Yep.
Get rid of that. Okay, sorry. Anyway, so in humans, we have 23 pairs of chromosomes, and you can see in women there are 2 X's, and then men have 1 fully formed X, and then they have kind of a stumpy chromosome, the Y chromosome. And I've been told that's because we're inferior to women, at least so my wife says. But in any case, so on all of these chromosomes, there are a number of genes that encode for proteins. And you can have mutations in, and you can have mutations in these genes that can, of course, cause a variety of disorders. So a couple of the disorders I'm going to talk about first are mutations actually on the X chromosome. And, but first, let me talk a little bit about certain types of mutations. So you can have what are called somatic mutations and or germline mutations. And so somatic mutations are an alteration in the DNA that occurs after conception. And sometimes we refer to these as acquired mutations. And so these are mutations that aren't really passed on, you know, from a hereditary standpoint, but are things that are acquired during our lives. And so these are kind of the ones that we often associate with things causing cancer or other diseases, again, that are acquired. And that's as opposed to germline mutations, which are gene changes in the body's reproductive cells, either egg or sperm. And so these are ultimately become incorporated into every cell of the body and can be passed on from parents to offspring. All right, so as I was saying, I'm going to talk about mutations that happen on the X chromosome, okay? And so two of the genes that are located on the X chromosome, and obviously there are many of them, but two of them are factor 8 and factor 9. So what are these factors? So these are clotting factors in the blood that help your blood clot, and people can have mutations in them that cause them either not to function or be produced in very low amounts, and therefore they tend to bleed. And I just wanted to go over how these particular diseases are inherited. So because they're on the X chromosome, they're inherited in what's called an X-linked manner, or an X-linked dominant fashion. And so, for example, because males only have one X, they're kind of at a disadvantage. In other words, if they have a mutation in one of the X chromosome genes, they have a much higher rate of having a significant illness, whereas the females tend to just be carriers of these illnesses. So this is just, again, a depiction that if you have a mother who has one mutated X chromosome and one normal one, and then a father who does not have hemophilia, you can see the children can be distributed in this kind of way. So for example, of the males that they could have, who are all going to have an X and a Y, 50% of them are actually going to have hemophilia, because the male is going to have a mutated X that has a non-functional factor protein, and then have the disease. Whereas any female that gets the mutated X chromosome is just going to be a carrier of that disease, because the father is, of course, going to give her a normal X. Okay. So what are these diseases? So like I said, they are severe bleeding disorders, and hemophilia A is caused by a mutation in the factor 8 gene, and accounts for about 4/5 of the hemophilia patients in around the world. And then factor 9 is called hemophilia B, which accounts for about 1/5. And as I said, these are the most common hemophilias. There is another one that's sometimes referred to as hemophilia C, which is caused by mutations in factor 11, but that's much more rare. And then there are also a number of other bleeding disorders that tend to be less severe, and I'm going to talk about one of those next. And in general, those are not X-linked, though, and those are carried on the autosomal chromosomes, the non-sex chromosomes. All right, so this is a depiction of the clotting cascade and what happens when your blood is supposed to clot. And so, for example, you have a blood vessel here, and you may have a cut, or you're slicing a bagel and you get a cut in your blood vessel. And the first thing that happens, of course, is some of the blood cells start to come out and you get bleeding. And then pretty quickly after that, these little tiny cells called platelets come together and start to plug up the hole. And that's what's called primary hemostasis. And then kind of the secondary step that happens is these little yellow fibers have to appear, which are called fibrin. And that forms the definitive blood clot. And in order for a fibrin clot to form, you need to have this pathway intact. And I'm just going to show you briefly. You can see factor 9 is right there, and factor 8 is right there. So if you're deficient in those, this fibrin does not form as well, and therefore you get impaired clot formation, and ultimately you get bleeding. Now, of course, you can have deficiencies in a number of these proteins and get bleeding disorders related to those, but by far the most common factor deficiencies in this cascade are going to be 8 and 9. And this is just a picture of the factor 8 protein, and this is the factor 9 protein. And you can see factor 8 is quite a bit bigger than factor 9, actually. So what are the clinical features of hemophilia? Well, for the most part, not enough factor 8 or 9 causes clots not to form that well. And therefore, patients can have spontaneous bleeding into their joints and muscles. And they can also have life-threatening bleeding into their brains or their abdomens, especially after trauma or even after routine surgeries. So what are some of the implications? Well, with regards to the spontaneous bleeding in the joints, this is just a picture of a knee joint. And here's a healthy joint that has a normal synovial membrane and a normal joint, and normal bone. But what happens in severe hemophilia patients, again, either A or B, they can get bleeding into these joints spontaneously because just normal use of our knees and our elbows and our ankles results in these micro bleeds. And usually we're able to, heal those up just fine without any problems at all. But in patients with hemophilia, they actually have chronic bleeding into their joints. And it causes blood to build up. It causes the synovium to get inflamed. And it can cause bone changes as well. And what happens over time, and it can be in patients in childhood who aren't appropriately treated, it can happen very early. They get these giant swollen joints, and these findings are actually permanent. These do not normalize, and they have very impaired range of motion. Sometimes they have chronic pain in those joints, and it really affects their quality of life. So what we've learned over time is that we can prevent these chronic joint issues by actually giving prophylactic factor therapy. So how is that given? Well, for the most part, at least up until recently, it was all required to be intravenous. So in other words, you actually had to start a little IV or a butterfly needle and insert it into the vein and give the IV factor therapy. And for patients with factor VIII deficiency or hemophilia A, they would need to get these IV therapies 2 to 3 times per week, and then a little bit less than that for the factor IX patients. But you can imagine in a 1-year-old who has hemophilia having to get a needle stuck in their arm 3 times per week is kind of a traumatic experience. But that's what we had to do to prevent bleeding into their joints and chronic joint damage. So these days it's highly recommended, and most families are able to do this, are able to do 2 to 3 times per week factor therapy for the hemophilia A patients. And when they do that, they basically can normalize these patients' lives. So in other words, they're going to prevent chronic joint damage, and it also prevents bleeds due to normal activities as well. And so these kids, for the most part, can otherwise lead normal lives. They can play sports, they can ride roller coasters, they can, again, for the most part, do whatever they want within reason and with appropriate care. And so that is kind of my segment on hemophilia. And I'm going to kind of move on to a less severe bleeding disorder, but one that's actually quite a bit more common. And the disease that has to do with is this factor called von Willebrand factor. Now, von Willebrand factor doesn't really occur in this part of the cascade. It actually occurs up here where the platelets first start to go to the site of injury. And in fact, von Willebrand factor's role is to recruit platelets to the injured endothelium. And so it's kind of hard to see, but the von Willebrand factor are these little half circle things there that are holding the platelets to the endothelium. So if you are deficient in von Willebrand factor, you have a defect in this process. And that causes some different types of bleeding. It doesn't really cause bleeding into the joints and muscles, but it causes some other types. And this is just another picture of the function of von Willebrand factor. Von Willebrand factor is actually a very large protein, and it floats around in the bloodstream, and also is found in platelets and in the endothelium. It's kind of in these clumps. And when there's injured endothelium, the von Willebrand factor finds it pretty quickly and binds, and it actually responds to shear stress. So as the blood flows by this damaged endothelium, the von Willebrand factor gets stretched, and then it's able to recruit the platelets. And that's the thing that helps the platelets clump onto the site of the damaged blood vessel. And so a little bit more about von Willebrand disease. So people with von Willebrand disease either have low levels of von Willebrand disease or they have a defective protein that doesn't work the way it should. It is the most common bleeding disorder, and some people have suggested it's found in up to 1% of the US population, which is very common. And then although it occurs among men and women equally, oftentimes we find it quicker in women, and often women have more severe symptoms due to heavier abnormal bleeding during menstrual periods and after childbirth. And in general, there are three major types of von Willebrand disease: type 1, 2, and 3, with types 1 and 3 are what are called the quantitative defects. So 1 is a more mild quantitative defect, so the amount of von Willebrands is less. And then type 3 is a severe deficiency of von Willebrand disease, and actually presents quite a bit like hemophilia. And then the type 2 patients have what's called a functional defect in von Willebrand, or a qualitative deficiency. And they tend to have more severe bleeding than the type 1s. So how do we treat von Willebrand disease? Well, and I'm not going to go into this in too much detail, but for the most part, unlike hemophilia, where the treatment is chronic and every week, 3 times a week, von Willebrand treatment tends to be more episodic. So you just treat it as needed. And there's a number of medicines under the category called antifibrinolytics that help blood clots not break down as fast. There's a medicine called DDAVP that is able to stimulate von Willebrand factor in the blood. And so even if you're a little bit low, you can give this medicine and it causes the levels to go back up to more near normal. And then finally, there are factor products that, again, are intravenous that can be given for patients with more severe von Willebrand disease. Again, there's a whole variety of products that exist for that purpose as well. So a few other clinical findings for von Willebrand disease. It can present with severe bleeding following tonsillectomy or other ear, nose, throat type procedures. And we get a fair number of referrals with regards to that. Like it'll be a kid who had a lot of snoring and needed to get their tonsils taken out, and then they're found post-operatively to have excessive bleeding. And so we'll get referred those patients to work up for von Willebrand disease. And then even more than that, we get teenage women with heavy menstrual bleeding, or even some who present to the emergency room with severe anemia due to chronic heavy menstrual bleeding. So that's often how we diagnose these patients. And we know that, even though this is a more mild bleeding disorder, it actually does affect quality of life by quite a bit, and it can cause many missed school days due to, heavy nosebleeds or heavy menstrual bleeding. And we know that there's a higher incidence of mental health issues and school difficulties in these children as well due to these issues. So we definitely want to know about these patients who have these even more mild bleeding disorders, because it does cause an effect on their lives. And then finally, from a kind of a world health standpoint, this really is a public health issue, because postpartum hemorrhage actually affects 6% of all deliveries worldwide and is the leading cause of maternal death. And when they've studied this, in many cases, it's often due to undiagnosed bleeding disorders, such as von Willebrand disease. So maybe, if it's okay, I don't know if any questions have come through. I was going to pause there for a sec.
None in the chat so far, Dr. Lasky.
Okay. So I went back to DNA again, because I was going to kind of switch up to another genetic disorder that doesn't have to do with bleeding, but is a form of anemia. And the anemia I'm going to talk about is one called sickle cell anemia, or also known as sickle cell disease. And of course, I could give a many-hour talk about just any one of these disorders, but I'm going to give kind of a brief overview about sickle cell disease. So unlike the hemophilias, the genetic mutation in sickle cell disease is not on one of the sex chromosomes, it's on one of the autosomal chromosomes, okay? And it happens to be on chromosome 11. And this is kind of a noisy slide here, but so here's our chromosome 11. And one of the components of hemoglobin is something called the beta subunit, or the beta globin gene, okay? And normal hemoglobin, which kind of looks like this, is made up of 2 normal beta globin genes and 2 normal alpha globin genes. And the beta globin genes happen to be on chromosome 11, and the alpha globin genes are on chromosome 16. And when you get a mutation in this beta globin protein, and it's a particular mutation that changes one of the amino acids here from glutamine to a valine, or glutamate to a valine, it causes the hemoglobin in the red blood cells to polymerize and do kind of funny things, all right? And as a result, it causes normal red blood cells, which tend to look like kind of these flat, nice looking pancakes. It causes them to turn into these sickle cell shapes, or C shapes, okay? And these cause lots of problems and cause the disease known as sickle cell disease. Now, in order to get the sickle cell disease, you do need 2 copies of the mutation. So this shows, a father and a mother. And so when you only have 1 abnormal copy of the sickle gene, you have what's called sickle cell trait, which for the most part doesn't have any symptoms at all. And you can't tell someone has sickle cell trait. But if one person with sickle cell trait gets together with another, they have a 25% chance of then having an infant, with sickle cell disease, okay? And then there's also a 50% chance that the children may be carriers or have sickle cell trait as well. And so what are the implications of having sickle cell disease? Well, again, like I said, it causes these kind of normal, flexible red blood cells to turn into these very rigid sickle cell blood cells that can clog up blood vessels and again cause the pathology that we see in sickle cell. So, where did sickle cell come from? And I find it kind of interesting about the history of this disease, but it's actually thought that this mutation arose about 7,000 to 10,000 years ago, although there's still some debates about that. And I think it may have originated somewhere in a country in Africa called Cameroon. And we're pretty sure that it arose in the gene pool because people with sickle cell trait are actually protected against severe malaria infection. And so they think that, there was enough genetic, effects at this time that it caused this gene to propagate because of the protection against malaria. And basically this gene then, spread out, first of all, to all of Africa, and then it also spread into the Saudi Arabian Peninsula and even into India. And then ultimately it was brought to, the Americas with, the slave trade really, and is now found really throughout the world, again, still mainly in Africa, but also throughout the Americas as well. And I didn't go into these details, but sickle cell disease is a group of inherited red blood cell disorders. And the reason I say that is there are some other mutations in the hemoglobin that can occur along with the usual sickle cell mutation that can also result in a similar clinical disease that sickle cell anemia. So we call them all sickle cell disease, but sometimes the genetics can be a little bit different. But basically what, as I said, what happens is that healthy red blood cells tend to be round and flexible and can get through blood vessels easily. Whereas in someone with sickle cell disease, the red blood cells become hard and sticky and start to sickle up like this and start to clog up vessels. And one of the other facts about red blood cells that have a lot of sickle hemoglobin in them is that those cells actually die early because they get kind of destroyed in the small blood vessels of the liver and the spleen, and they also get caught up in the kidney as well. Basically, like I said, these just red blood cells are not particularly healthy. Now, if they have enough oxygen, they tend to stay in their round shape, and it's when they get into the lower oxygen tensions of the kidney, or if a patient has an illness that causes them to have a little bit of a low oxygen from a cough or asthma, it can worsen this sickling and cause lots of issues. And so some of the things that these patients can experience are chronic pain issues, chronic pneumonias, and it could even cause permanent brain damage due to strokes as well. So how do we treat sickle cell? Well, for the most part, it's supportive care. In other words, we treat the symptoms. And so one of the main symptoms that happen, especially in older patients with sickle cell disease, is they have lots of chronic pain. And again, this is due to red blood cell sickling, mainly in their bones, and it can cause infarcts or death of little parts of the bone, and that causes quite a bit of pain. Because one of the organs, the spleen, which is very important for fighting infections, but in patients with sickle cell, the spleen does not work very well. And in fact, eventually it shrinks and becomes non-functional. They're at quite high risk for bacterial infections as well. And so we're very quick to treat them with antibiotics. There are some newer medications that exist now that can help to modify the disease and cause some of the sickling to be a little bit less, although not completely. And those have names like hydroxyurea, glutamine, and some long names, crizanlizumab and voxelotor, which are newer medicines that have just been approved. And then finally, you can do kind of more invasive treatments as well. So blood transfusions do help, and we do have some patients with sickle cell who are on chronic blood transfusion therapy, but that causes problems of its own, including getting too much iron in your liver and in your heart. And then also, having to come in every 3 to 4 weeks to get blood transfusions and get an IV and having to spend time doing that. And so that, leads us to what, is there any cure for this disease? And there is the one that's, been well studied and is a known cure is bone marrow transplant. However, and I'm not going to talk a whole lot about that, but bone marrow transplant isn't a walk in the park. In other words, it has lots of side effects and mortality built into those procedures as well. And kind of what is up and coming are things like gene therapy, which I'll touch on near the end. But again, that's very much in its infancy and hasn't entered widespread use yet. And then finally, I just want to touch upon, again, kind of world health perspective of these diseases. So, you can imagine in the United States, there are 100,000 people with sickle cell disease, and their life expectancy is only 54 years as compared to, 75 to 80 years for patients without sickle cell disease. And then let's go to a smaller country called Nigeria, which has 4.8 million people with sickle cell disease. So, if you talk to pediatric hematologists in the US, we think we have a tough time of, taking care of patients with sickle cell disease. But in Nigeria, it's just way more. And so it's really, there's a dire need for getting further medical care to these patients. And I can say with fair certainty that the life expectancy in Nigeria is probably a lot less than 54 years. So this, truly is a public health issue, and one that, we need to continue to do research on. All right, so back to my chromosomes again. I don't know, any questions or any comments yet? Okay. All right. So, so having talked about, what we know is benign hematology, although one could argue whether any of those diseases is benign. Obviously, hemophilia A and B can cause chronic joint disease. Sickle cell anemia can cause lots of complications, shortened lifespan, and chronic pain. But again, they're technically not malignancies. And so I'm going to move a little bit into cancer in children. And as I said, whereas the other diseases were, due to what are called germline mutations or hereditary diseases, for the most part, pediatric cancers are not hereditary, although there are certain syndromes that can predispose you to cancer, and those certainly are hereditary. But most of what we deal with regards to pediatric cancer are diseases that are sporadic. In other words, we don't really know what causes them. There may be some environmental factors, but we're kind of still working to figure those out. We obviously know certain things like exposure to radiation therapy can cause, cancer, but for the most part, our diseases are sporadic, and we never really find out what causes them. So what kind of cancer do kids get? So first of all, probably about 15 to 20,000 children per year in the US are diagnosed with cancer, okay? Now, that's compared to about 400 to 500,000 women in the US are diagnosed with breast cancer per year. So in other words, child cancer in the scheme of things is a pretty rare disease, but still 20,000 cases per year, is still too much. And, again, we obviously see a lot of it here. So what are the cancers that kids get? And this is just a pie chart. They don't have the labels on the pie, but you can kind of see here were my top three. So leukemia, big one in blue, and then brain tumors or central nervous system is CNS, and then lymphomas. And then, of course, there are a whole number of other cancers that kids can get, including sarcomas and neuroblastomas and Wilms tumors and other things. So again, because the subject of childhood cancer, of course, is incredibly broad and would take, it took me 3 years of fellowship to learn a little bit of it. So I don't have time to do that, but I'll talk a little bit about leukemia, which is the most common type of cancer in children. And specifically, the most common type is what's called acute lymphoblastic leukemia. And so my little bit of history here is mainly focused on acute lymphoblastic leukemia. The other form, acute myeloid leukemia, is much less common and also much less curable. But to talk a little bit about, ALL is what I'm going to focus on. So first of all, the acute lymphoblastic leukemias account for about 30% of childhood cancers. And even though, I told you that today it's actually very curable, until about the 1960s, it was really invariably fatal. So we've made, in the last 60 years, an incredible amount of progress in treating these. So the initial goal was to induce remission of leukemia, and this term is used for all cancers, but so patients with leukemia would come and present with, anemia, severe low platelets, so they'd be bleeding. They might have, fevers and infections. And then basically the, doctor would check blood counts and they'd find their white blood cell count would be really, really high. And that's what, defines leukemia. And basically, as I said, up until around 1950, 1960, it was pretty much a death sentence, and you just made those children comfortable, and that was really all you could do. So back around the time after World War II, they started to come up with some compounds that actually did affect cancer cells, and some of them were actually developed from the nitrogen mustards that were used as part of war, and they found out that some of these compounds actually killed leukemia cells too. But one of the first medications that was developed to fight against leukemia was this one called methotrexate. And it was developed by this guy, Dr. Farber, who's part of like the Dana-Farber Hospital in Boston. And he found that this molecule could induce remission in 40% of children with ALL. And remission at that time was defined as making the disease not clinically visible. So in other words, it made their spleens go back to normal size, it made them feel better. So we didn't really have the technology to actually look in the bone marrow as well to see if they were really, cured or not, but we knew we got them into what's called remission. The problem is with just this drug alone, or even some other drugs that were discovered at the time, we knew that if you only use that one drug, these patients would eventually relapse and die of leukemia. And so another, medicine that was made again back in the 1950s was a drug called mercaptopurine, and they found out that it also was effective in ALL, and that was done at Memorial Sloan Kettering Cancer Center. So the problem, however, was that although these drugs worked for a while, the leukemias eventually became resistant to them, and then the leukemia would come back. So another medication that actually was even a little more effective in treating ALL was the simple medicine prednisone, which of course is used for a lot of different illnesses. It's used for asthma, it's used for lupus, it's used for other immune conditions. But it's actually one of the most effective medications for ALL as well, and actually induced remission in about 60% of patients. But again, the same problem occurred, which is that they would go into remission for a while, but then the disease would come back. And so, basically what they thought was happening is that you can think, when a child or an adult starts to develop leukemia, there's like one little cell that goes abnormal and gets a genetic mutation, a somatic mutation, and then it starts to grow. And the number of cells that it takes to actually make someone present with leukemia is probably a huge amount, even as many as 10 to the 10th cells. So a huge number of cells before you can even detect the leukemia. And so then they come in with their high white blood count and fevers and whatnot. And then we give them the drugs to try to cure their leukemia. But the problem is that, there's probably a number of these, millions and millions of cells. There's a lot of them that are sensitive to the medicine, but there's some that are resistant. And it's the resistant ones that then come back and result in relapse again. So the key was to try to find a way to, keep giving medicines that are going to overcome that resistance and get, a person back to zero again. And so again, research continued. There's a medicine commonly used called vincristine. It apparently was used for diabetic cows, but it didn't apparently work that well for the diabetic cows, but it worked really good for children with ALL. And what they started to do later, in the 50s and into the 60s, is they started to combine these agents. And they discovered that instead of just giving one alone, maybe you had to give a combination of drugs to work. And they started to do that. And one of the things that also happened in the 70s, and if you remember, this was around the time when the war on cancer was declared as well, the National Cancer Institute was kind of founded, and it started to support what are called cooperative groups. In other words, groups of investigators that were concentrated in investigating cancers. And so there were adult cooperative groups, and there are also pediatric oncology groups. And one of the first ones was called the Children's Cancer Group, and they started conducting trials combining different agents that were active. And basically they discovered that they could add this other medicine called asparaginase to the vincristine and the prednisone. And they started to actually cure children of their leukemia. Now the cure rates were still, very dismal, but they were starting to have some success. And basically they started adding more and more phases onto therapy, and they called them different names. There was induction, which was the first step, and then consolidation. St. Jude researchers discovered fairly early on that even if you cleared the bone marrow of the leukemia, which is where the leukemia starts, it is in the middle of the bones, the bone marrow, you could still get relapses in the brain and spinal fluid. And in order to prevent those relapses, you actually needed to do spinal taps or lumbar punctures to do that. And that was introduced eventually in the early 70s. And then they started to add more and more kind of chemotherapy courses to acute lymphoblastic leukemia therapy. And basically, what has come out of the last 60 years of research into ALL is this kind of standard schema for ALL therapy, where you have about 6 months of fairly intensive treatment, and then you have about 2 years of much more mild treatment. And it's the phase called maintenance therapy. And I'm not going to go into the details of all this, but basically, from a research standpoint, this is what has resulted. So this bottom line is survival rate of ALL from 1968 to 1970. And you can see we have a survival rate somewhere less than 10%. And then over the next many decades, we're now, and this is still a little old, but you can see now we're, above 90%, almost 95% overall survival rates. And these are, I think, 5-year overall survival rates. And for the most part, if you survive 5 years after your diagnosis of leukemia, for the most part, we call that cure, because it's actually quite rare for leukemia to, come back after that standpoint. So really, we're looking at 90–95% cure rates for childhood ALL nowadays, and we're probably even a little higher than that in 2022. And well, I showed this picture, which is like our standard therapy and all of these drugs. And fact of the matter is, these cure rates that we have now in 2022 have all been achieved using medications that were developed in the 1950s. So in other words, we're still using the medications that are decades old and achieving excellent survival rates. However, that does come with some cost. And so this is kind of my complicated chemotherapy slide. But in all of these, kind of long names are types of chemotherapies that we use for a variety of different cancers. And there's kind of a common theme, is that they all affect DNA replication in some way, or they affect protein translation in some way. And the problem with affecting those pathways is that those are also incredibly important for brain growth, for bone growth, for organ development in these young, developing children. And so, giving all of these medicines does have long-term effects. And, we know, we do know that the most severe side effects come from things like radiation therapy, which we're really trying to limit now in pediatric patients, but sometimes we still need to use. But we also know that the chemotherapies that we use can cause some of these things too. And it can cause endocrine problems, it can cause hearing problems, it can cause heart damage. This is now a really big topic, is treatment-related obesity and metabolic syndrome. So we know our kids who are survivors of ALL, they're doing pretty good, and they're living, and they're being successful, but they're having more problems with obesity, they're having more problems with cardiovascular disease. Although it's hard for us to test these concepts, we think there's something to do with the therapies that they got that are causing them to be at risk for these things. Infertility, is an issue that's, coming about as well, because we're now getting, patients who were treated in the 1990s who are now, in their 30s and 40s and maybe trying to have children and having issues with it. So we're just learning about these finally after all these years. And so I think what that, behooves us to do is to try to develop therapies with less toxicity. And that is ongoing, but it's been kind of, slow, partly due to the fact that drug companies don't make as much money off of pediatric cancers as they do adult cancers. So there hasn't been quite as much research focus on pediatric cancers. But the other problem is that even if we try to target other things in cancer cells, they may not have the same side effects as the chemotherapies I've talked about. They also have their own set of side effects, and oftentimes they do have long-term side effects that we just don't know about yet. So we have to be very careful about developing, new therapies for kids, just due to the fact that we don't know yet what the long-term effects can be. And so just to talk a little bit about, what new things we might do to help, treat childhood with leukemia in a more specific way. Again, this is a very complicated slide that is mainly based actually on breast cancer treatment. But basically, the point is that in addition to, DNA synthesis, there are other targets in the cells that you can try to treat. And so there are these things called growth factor receptors and a whole number of transcription factors and kinases in these cells that have gone abnormal and caused these cells to grow. So one might think if you can block them with certain drugs, you can, help to make the cancers not grow and hopefully cure them. So there are certain diseases now, even in pediatrics, where we are using some of these targeted therapies to try to, achieve better results and better efficacy without, sacrificing side effects. And this is just, a list of, what are called kinase inhibitors that are now FDA approved for cancer therapy. And so there's a huge number of them. But again, I want to emphasize, what we've learned is that even though these are targeted agents, they actually do have their own set of side effects. And some of them actually do have side effects on growing, children, especially with regards to bone growth and other organ function issues. So again, even though they're targeted, we need to be careful with them. So those are the kind of targeted molecular agents that have been talked about, over the last 20 years. Kind of a newer phenomenon, or it's not that new, but it's become more and more, I think, in the news, and it's again becoming more and more useful for therapy now that we have better drugs to help with this, is the field of immunotherapy. So using the immune system to attack cancer has been, attempts have been made to use this approach for a long time, for several decades. But it's really only been recently that we've, kind of discovered some methods by which to harness the immune system that actually work. So in other words, there have been lots of clinical trials in the past that have attempted to get the immune system to attack cancer, but in large cases, they've failed, okay? But some of the kind of newer immune type therapies we're using nowadays are what are called monoclonal antibody therapies. So in other words, these are taking, antibodies, which of course we have in our body, and they are used to, attack, bacteria or viruses and stuff like that. But what we do now is we develop our own antibodies to go attack things on cancer cells. So for example, rituximab is an antibody that attacks this protein called CD20, which is found on almost all B-cell lymphomas, and there are certain leukemias as well that it can treat as well. And so that's, one example. Dinutuximab is approved for treating neuroblastoma, which has this protein on its surface. Blinatumomab is a very kind of hot agent right now being used in patients with relapsed, or even it's starting to enter into patients who are newly diagnosed with B-ALL as well. And so this drug we're now using more and more. And again, it targets this particular protein that's found on most acute lymphoblastic leukemias, okay? And then finally, another way of doing things is this drug called inotuzumab, which is an antibody that's against this protein, but it's actually hooked to a toxin. So you can imagine the antibody goes and finds the leukemia cells, and then it releases this toxin. And instead of, having toxicity for normal cells, it focuses on just the leukemia cells that are positive for that protein. So these are all methods by which to use antibodies to achieve therapeutic responses. Kind of one of the newer ways of harnessing the immune system now is a class of drugs called checkpoint inhibitors. Two of the ones that are often advertised now, Yervoy and Keytruda. So these are molecules that take the brakes off of the immune system. So this set of proteins here on the left, this TCR and CD28, these are immune stimulatory molecules. And so in order for the T cell to get excited about a tumor cell, it has to be stimulated by those two things. However, the body has these natural brakes on the immune system, and specifically these two right here, CTLA4 and PD1. And so the tumor cells often learn to display the brake signals too. And what that does is it stops these. So these put the brake on the T cells. That's what these lines stand for. So the PD1 inhibitors and the CTLA4 inhibitors, they actually block the brakes. So in other words, they let the foot off the pedal and try to get the immune system to respond more. And we're seeing some exciting responses in certain solid tumors and certain leukemias as well. But again, we're still working on figuring out what diseases these are going to work best for. And then that brings us to kind of even more modern immunotherapy approaches, which really have only been in wide use, so probably for the last 3 to 4 years, and are still really very new. And one of the only kind of what we call adoptive immunotherapy approaches that's FDA approved are these things called CAR T cells, and that stands for chimeric antigen receptor T cells. Okay, and there's a few other FDA approved ones, but the ones that I've had most experience with, and most pediatric centers have had experience with, is this one called Kymriah and Tectaris, and for the most part they act about the same. But basically what it involves is you actually need to take out the white blood cells of the patient, okay, and that's called leukapheresis. And then you sort out the T cells out of that bag and you put them in a dish. And then you need to actually infect the patient's own T cells with a virus, okay? And it's a virus that then puts a gene back into those T cells. And what that gene does is it tells the T cells to go attack the leukemia cells. So the T cells that they took out in the first place, maybe they were T cells that were meant to fight the flu, or maybe they were meant to fight COVID, or maybe they were meant to fight, a pneumonia or something like that. And what adding the virus does is it kind of says, okay, stop attacking those things. We want you to go attack leukemia cells. And then they expand those in the dish a little bit, and then they re-inject those back into the patient to go find and kill those leukemia cells. Okay. And as I said, we are having some successes, using this approach, but it is fairly, work intensive, and a lot of things can go wrong in the meantime. The cells may not grow, the cells may get infected while they're in the dish, the virus may not work. So, this is still a bit of a work in progress, but again, these therapies are FDA approved now and are being used predominantly in the relapsed setting. So in general, these are kids who have already gotten chemotherapy and then they relapse from their leukemia, and they can go on to receive this therapy. Unfortunately, right now, we do not have these capabilities in Nevada, and we're having to send people out to get those, but we're working to actually be able to do this locally, but it's going to take a little while to get the appropriate cellular therapeutic infrastructure in place, and so that's in process. And then, although this is kind of a form of gene therapy, in other words, we are modifying cells, in a way. The other thing I wanted to just touch on was kind of what I call true gene therapy. In other words, gene therapy that is going to replace a defective gene. So whereas, this type of approach is good for, killing cancer cells, these cells eventually do go away. So in other words, they don't stick around forever, right? So in order to cure a disease like hemophilia or sickle cell disease, you don't want, the cells to just be there for a while and then disappear, because then, you're not curing the disease. So what these therapies are trying to do is actually replace genes with, a working gene, and then we want the expression of those genes to be persistent. So this, I'm taking some of these slides from a talk that was from 2018 by this guy, Dr. Ayudi, but I thought it was a good kind of summary of what this is about. And this is, again, it kind of explains, I think, quite a lot. So in other words, there are kind of two ways to do gene therapy. You can do what's called ex vivo, which is you would take cells out of the body and then do something to the cells and then put them back in the body. Or you can do what's called in vivo gene therapy, where you actually just take a gene vector, usually again a virus, and inject it directly into the organ or the location that you want the gene to be produced. And so so ex vivo approaches are being used for these type of diseases. So the primary immunodeficiencies are diseases where you have a mutation in a gene that causes your immune system not to do something correctly. Maybe it makes it not make T cells or not make B cells. And so if there's just one gene that's wrong, if you could replace that gene, that child is going to make those things again. And the same thing goes for things like hemoglobinopathies, of which sickle cell is a form. So if you can take cells out that have a defective gene, such as the beta globin gene in sickle cell disease, and you can replace it with a normal beta globin gene, you're going to cure that patient of their sickle cell disease. Okay. And then these kind of in vivo approaches have been used for some other disorders. So there's a very severe set of genetic disorders called lysosomal storage disorders that cause progressive brain damage starting from infancy. And some of these diseases are like MPS types 1, 2, and 3. There's a whole variety of different lysosomal storage diseases. And some of the main effects that these diseases affect are again, in the brain, and it causes progressive neurodegeneration. And so there have been studies looking at injecting viral gene vectors directly into the brain or into the spinal fluid of the brain to try to get the brain to make these essential proteins that are missing in these patients to try to prevent these degenerative brain diseases. But again, these are very much in their infancy, but that's being looked at. However, so from a hematology standpoint, though, we're very excited about progress that's being made in curing factor 8 and factor 9 deficiency. And I'll talk in a second about how some of these vectors are being used for that. And so, what are these viruses that are being used? I'm not going to dwell on this slide too much, but you can see there's a whole bunch of different viruses that are being used to try to insert genes into, whatever cell type you're trying to get it into. Because basically you need a vector to bring the good gene into the cells, okay? And so this is kind of a rough example of what's being done for hemophilia B, or factor 9 deficiency, where they have an adenovirus vector that has a special form of the factor 9 gene, and they inject it into the blood, but this adenovirus is especially attracted to liver cells. And so even though it's injected into the bloodstream, it goes very quickly to the liver and it infects the liver, but it infects it in a way such that this, the gene that's inserted kind of lives within the cells of the liver, and it starts to actually make the protein, the factor 9 protein. And we now have patients with factor 9 deficiency who've been injected with these type of viruses that are now 4 or 5 years out and still making factor 9. So even though the rest of their body is still mutated, in other words, they have the factor 9 mutation, they have some cells living in their liver that actually can make factor 9. And a lot of them have no more bleeding, they don't need to take factor anymore, and they're essentially cured of their hemophilia B. Now, we're still following these patients very closely because it's possible they could lose these vectors over time, but so they're being carefully monitored for that. Now, we're also obviously monitoring for side effects of gene therapy as well, and we want to make sure that when we do put a gene in someone, that it doesn't cause something bad. In other words, we want to make sure it's not causing cancer or other disorders that are going to be worse than the original disease in the first place. So these risks are there, and we're watching for these very closely. And so there's none of these type of therapies are FDA approved yet. I believe there are some that have recently been approved in Europe, but the FDA has been very careful about looking at these, and that they have not approved anything yet. But I think it's coming. And then finally, the other kind of topic that's been in the magazines and on TV is actual gene editing. So in these cases, you're having a virus go in and replace a gene or deliver a gene to a certain set of cells, whereas in true gene editing, you're actually taking certain special proteins that actually edit your own DNA and potentially then get it to repair in a different way. And you may have heard about CRISPR technology in the news and in magazines and stuff. So these are, again, still very much in their infancy, but with further research, this may be a way of the future as well. And these kind of techniques may not just be useful for things like hemophilia and sickle cell, but there may even be utility in treating cancers with these too. For example, maybe to even modify the immune systems in such a way to actually, again, to go attack the cancer, which we have other medicines that we're trying to get to do that, but sometimes the cancer is just too smart. So if we can actually edit things, maybe we can make them, permanently go after the cancer and have, again, persistence of an immune response. And so that really is my last slide. But again, just to summarize, pediatric hematology, oncology, we, like I said, we see a lot of different things. And, there are, again, benign blood disorders, but I want to emphasize again that even though they're benign, that they do cause quality of life issues and public health issues for these patients, and need continued research. And a lot of them do not have cures yet. We're able to use medicines to help, people live with these diseases, but if possible, we'd like to cure them one of these days. And so that work is ongoing, and I thank you for learning about it and supporting the research we do here at Cure for the Kids and the research that's going on around the world to help fight these devastating diseases. Thank you.
Thank you, Dr. Lasky. That was fascinating. I just want to open it up to questions. I know I have a question, but I would like to see if anyone else has a question that they'd like to ask first. Feel free to unmute yourself or put it in the chat. Any questions? Okay. Well, I'm going to ask my question because maybe that'll spur others. So and this is a very, pardon me if this is a naive question, but in the early 2000s, there was a lot of talk about cord blood and cord blood banking and storage to use stem cells to help with curing blood disorders and cancers. But you don't really hear about that much anymore. Has that been used, or has that been discontinued, or what is the status of that?
So, right. And so let's see. So there were, a lot of, there was a lot of excitement about maybe using these stem cells to, generate new organs for people, and, and even injecting directly into the brains, to stimulate, neural regeneration and stuff. But I guess for the most part, most of the initial studies where they used the cells in those fashion, it just didn't work. In other words, I think it underlies, there's a lot of complicated things that happen between the stem cell that's, in an embryo, and then what happens in a full, grown adult. In other words, there's lots of cellular pathways that are inactivated and activated. And I think the idea that just injecting something somewhere, was never going to pan out. Now, there's definitely still further research about using those type of cells to, again, to regenerate organs, to regenerate skin, to regenerate nerve cells. But I think it's going to take a while for that to mature. Now, what we do use, umbilical cord stem cells for is we do use those to treat, malignant diseases that have recurred. In other words, we use them as bone marrow transplant sources. And they're very useful for that. So there are giant cord blood banks, public cord blood banks that are able to be used in that setting. So for example, we have a number of kids now who had leukemias who then recurred, and we send them out to transplant centers, and they're able to find cord blood units that are in those public banks that are a match for a given individual. And there's some properties of cord blood stem cells that are, better than bone marrow stem cells, or better than peripheral blood stem cells for those patients. In other words, they have less side effects after bone marrow transplant, and they just tend to do better. So for that purpose, we definitely still, use use stem cells in that way.
Great. So those people that have taken part of storing their own children's umbilical cord cells should continue to pay their bill. It sounds like.
Right. And I think it's reasonable to do that. Again, for a given individual stem cells that are stored for them, there's really nothing to be done with them yet, but it's possible in the future there may be. But again, the research is still ongoing with that.
Thank you. Dr. Lazarson, do you have a question? You're muted, sir. Let's unmute you.
Mute. Okay. Very nice overview of Pete's hematology oncology thing. Really nice. I'm one of the old guys. Okay,
I know of you. Yes.
I lived through the early parts in the 1950s and 60s. And it won't change. So it's fantastic to see the growth and the evolution of all this, and the introduction of genetic alterations of diseases are really a key feature for most of this at this point. And somewhere down the line, it's going to be another technology. So it's interesting to hear the status. But you did a real nice job on the overview of Pete's heme.
Oh, thank you.
We're benign hematologists. That means I may be a malignant person, but I'm.
Oh, thank you.
Thank you, Jack. Any other questions? Dr. Thacker says that thank you, excellent presentation in the chat. All right. Well, thank you so much for this incredible presentation, and thank you for the work you do. It is so important. It's helping so many people. And thank you to all of our guests for being here tonight. And we'll see you next time. Stay well.
Awesome. Thank you.
Bye-bye.